Hello, all. My name is David Fox. I'm a family practice physician, um, currently working in the emergency room, but I spent several years overseas teaching residents. And one of the things that we would teach them every year was a simplified approach to reading ECGs. I think for anyone who is kind of starting out in ECG, whether you're a nurse or nursing student, medical student, intern, first year resident, this approach is super helpful at figuring out how to look at an ECG and get the basic things that you're looking for from it. So I hope that this series of lectures will be beneficial to you. What we're going to look at today is basically just the approach, something that I'm called a simplified systematic approach. And the reason we're going to do a simplified and systematic approach is because often when you are just starting out in ECGs, you might look at something like this ECG and you might feel like this guy over here, where you just feel overwhelmed. You feel like there's just too many bumps and squiggles and I can't figure out what's going on. And that's okay. That's normal. That's how we all feel when we start looking at ECGs. So what we're going to do is actually take some time and develop a system for breaking down the different parts of an ECG, and we'll talk about what those parts are here in a minute. And I'll just say briefly at the start that this idea of a simplified systematic approach is pretty common. You'll find it in lots of ECG textbooks and helps, and I'll share a couple of resources at the end of this lecture if you want to read a little more about it. So the question is, how do we go from something super complex and break it down to something that's readable and understandable? So in order to do that, we need to first understand what an ECG actually is. Of course, ECG, many of you who are coming from Europe and elsewhere, ECG sounds normal to you. Here in the US, we often call it an EKG. The K just comes from the German spelling of an electrocardiogram, cardio spelled with a K, and that made its way back into the English language. But in most of the world, it's known as an ECG, an electrocardiogram. So what are we actually looking at when we do an ECG and we capture all of those bumps and squiggles? What are we actually doing? Well, the first thing to realize is that we're looking at the electricity of the heart. So that's all. We're looking at electrical activity. And this is important because what we're trying to do clinically, most of us who are getting ECGs, is because we have a clinical concern. Maybe the patient is having a racing heart or palpitations or feeling lightheaded or having chest pain or trouble breathing. So we're getting an ECG in order to give us clues to their clinical situation, clues to their diagnosis. But what we have to understand is that an ECG is really just that. It's really just one of the tools that we use. And what it gives us is an electrical picture of the heart, or a picture of the heart's electricity at a certain moment in time. So it gives us what I've labeled here a snapshot. And I think this is really important because often the patient comes to see you and they say, oh, I had chest pain yesterday. Well, if you get an ECG today and they're not having any symptoms, chances are the ECG may look normal. And that's because you're just getting a snapshot. You're getting a moment in time. You're just getting a look at the heart for those few seconds that you're taking the ECG. And if the patient isn't having any symptoms, more than likely that ECG is going to look normal, unless there was some permanent damage done or some other clues that you might find. But generally speaking, your ECG is probably going to look fairly normal if there's no symptoms. So it's just giving you a picture in time. So just a little clinical pearl for you. If you're working in a hospital or in the ER on the wards, and the patient came in with chest pain, by the time you got the EKG, the chest pain was gone and you got a normal ECG, don't be afraid to get another one if the patient gets pain again. And then you can see if there's a change when the patient's actually having symptoms, because you really want to get that snapshot when the patient is feeling whatever the symptom is, lightheadedness, palpitations, chest pain, whatever. Okay, and then of course back to the electrical activity. This is important because it's not actually showing us blood flow. It's not actually showing us functionality of the heart. It's not actually showing us how efficiently the heart may be beating. All that it's really telling us is the electrical activity. And what we do clinically is we try to infer what might be going on with the circulation or with the functionality of the heart based on the electrical activity. So in order to kind of move forward and look at the electrical activity, we have to remember how the heart works electrically. And if you remember from your anatomy and physiology classes, the initial stimulus for a heartbeat begins in the upper part of the right atrium in a place called the sinoatrial node, or what we usually just call the SA node. And the electricity follows a very predictable pattern. So first it hits the atria, right? And of course it's going to hit the right first because that's where the SA node is, but it quickly crosses over to the left and stimulates the left atrium to contract as well. So we get first an electrical impulse from the right atrium, spreads over to the left atrium, and the two atria contract at nearly the same time, but the right atrium is going to contract just a tiny bit quicker than the left because the electricity gets there first. Then the electricity is going to move from the atria, if you remember, to the AV node, which is typically right at the junction of the atria and the ventricles, kind of near the septum between the two ventricles. And from there, the electricity goes down the bundle of His, and there's a right bundle and there's a left bundle. And then it goes around the bottom of each ventricle and stimulates what we call the Purkinje fibers, if you remember that. And the Purkinje fibers then stimulate the muscles themselves to actually contract. So the ventricles actually contract from the bottom up, because as the electrical stimulus is going down the right and left bundles, there's no signal to contract yet until they get to the bottom of the ventricles. And that's important because you want the bottom of the ventricles to squeeze first so that it squeezes the blood up and out. So remember that flow of electricity. SA node, right atrium, left atrium, AV node, bundle of His, Purkinje fibers, and then the two ventricles, again, nearly simultaneously. So the question is then, how do we capture that electrical signal? How do we know what the electricity is doing? And we do that by putting these leads on the chest. And I'm sure many of you have probably seen this. If not clinically, you've seen it on TV, watching some kind of television show or movie. But we put these stickers, basically, that have a metal clip, and we attach the ECG machine to these clips so that we can read the electricity at multiple places along the chest. And from those multiple areas, we can kind of put together almost a 3D idea or picture, or at least a two-dimensional picture of what the heart's electricity looks like at any particular moment. So there are several leads that we put on the patient. The main ones to talk about are 4 of them that we put on 2 on the arms and 2 on the legs. So we have a right arm lead, a left arm lead, and you can see in the picture here they're on the shoulder, and that's fine. Just as long as they're kind of near the shoulders and in the upper part of the chest or arm. And then right leg and left leg. Of course, we used to actually put them on the legs, and when I worked in Africa for a time, one of the ECG machines we had actually clipped onto the legs. But really, you just need to make sure that you get them below the heart. So they can be, for example, on the abdomen or around the pelvic area, as long as they're below the heart. So once you get those arm and leg leads on, you're going to then put the chest leads on. And the chest leads are what are labeled here: V1, V2, V3, V4, V5, V6. And I'm not going to go too much into how to place those. You can watch other videos for that, but just briefly, you're trying to get the V1, you just have to make sure is on the right side of the sternum at about the 4th intercostal space, and V2 just on the left. And then you want to get this midclavicular line for your V4 and kind of go between the 5th and 6th ribs there, or around the nipple line. And then in between you can put V3, and then V5 and V6 will kind of wrap around the lateral side of the left chest. So what's going on here is that we're looking at each of those leads tells us what does the electricity of the heart look like from that position. So the right arm lead is telling us what does the electricity in the heart look like if you were looking from here at the heart, or the right leg from here at the heart, or from the left leg from here at the heart. So you get an idea how you can get a picture. You can almost build a two-dimensional and sometimes three-dimensional, if you put leads on the back as well, idea of what the electricity in the heart is doing. All right, I'm trying to get this screen to move. There we go. All right, so you're getting typically a 12 lead view. So you might wonder, how do we get 12 leads out of, I think I just showed you 10 stickers. And that's just, if we go back real quick, that's because you're looking at what's the electricity going in this direction, from here to here, for example. What's the electricity going in this direction, and this direction, and this direction. So you can see that from those 4 leads, you can actually get 6 directions. So you're going to get what we call a 12 lead view. You're going to get 6 limb leads. The limb leads were the right arm, right leg, left arm, left leg, if you remember, and the 6 chest leads, which are labeled V, and then 1 through 6, V1, V2, V3, and so on. And what you get is kind of a snapshot at each of those locations of what the electricity of the heart is doing. And it reminds me a bit of a Picasso picture. If you see this Picasso down here, when I first took my kids to some art galleries and things like that in Europe, I really didn't know much about art myself, so I had to kind of read up and teach myself. And when I got to Picasso, I thought, how strange are these paintings? They're so weird, they're distorted, and they're kind of like 2 noses and 3 eyes, and very strange kind of looking pictures. And what I found out is that Picasso was actually trying to draw different parts of the picture from different perspectives. And that's why, for example, in this picture, you've got 2 nostrils that are quite separated. It's because he's showing you one part of the nostril maybe from a front view and one part of a nostril from a side view, and he's putting them together into one picture. And I thought, this is kind of like what we do in an ECG. It's much like a Picasso painting, where you're trying to take these individual pictures that you get from each of the leads, and then you're trying to smash them together to get an idea of what the entire electricity of the heart might be doing. So most people who learn and teach ECG will come across a picture like we have here with this circle and these different vectors. And what they're trying to show you is what the heart, the electricity of the heart looks like from different viewpoints. And so remember, on our ECG, we're going to get a 12 lead view. So, sorry, this is going on without me here. A 12 lead view. So what we're going to look at when we get to real ECGs is we're going to take a look at each of those leads, with the exception of one that we don't often use. And we're going to say, okay, what does this tell us about the atria? What does it tell us about the ventricles? What does it tell us about maybe a disruption in the flow of electricity? So each of those leads gives you a different view of the heart, and you put them together. So this picture here of the circle with all the arrows going through it kind of tells you, of those 12 leads, what part of the heart is each of those leads giving you a picture of. So you'll notice we have some pictures, or some colors here in blue and some in green. So the ones in blue are just Roman numeral numbered. So we have Roman numeral 1 and Roman numeral 2 and Roman numeral 3. So we call that lead 1, lead 2, and lead 3. You see the green ones are AVL, AVF, and AVR. So these are the 6 leads that come from the limb leads, from the right arm, right leg, left leg. We get these 6 views of the heart. So when you're looking at lead 1 on a ECG, what you're getting is kind of a left-sided or maybe lateral view of the chest. When you're looking at lead 2 and lead 3, you see here you're getting what we would call an inferior view. We call those the inferior leads. You can see that AVL is also kind of a lateral lead. It's showing you what's going on the left side of the chest. And you can see AVF would also be an inferior lead. AVR is kind of strange. It's kind of giving you a superior and right-sided view of the heart, which is not as clinically useful. And so most of the time, at least in our simplified approach, we're going to largely ignore lead AVR. All right, so what are the basics of the ECG with as far as what are you looking at when you're seeing the bumps and squiggles? What is it that you're actually capturing? What part of the electrical content of the heart are you able to see? And that's what this picture is really about. So we've got our picture of the electrical flow, you remember, on the bottom right here. And we've got a picture of a very kind of idealized ECG, what basically equals 1 heartbeat. Well, there's almost two heartbeats. 1.5 heartbeats are on that picture. So let's break apart what it is that we're actually seeing with these bumps and squiggles. So when we start reading an ECG, the first movement of the needle that you will see, the first bump that you will see is called a P wave. So the P wave, it's the first. So if you're thinking about the electricity in the heart, we know that the first thing that happens is the SA node kind of sends out that electrical signal, and that electrical signal goes to both of the atria, and then the atria contract, right? So electrically, the P wave represents atrial depolarization. If you remember from physiology, depolarization is when the electrical content of the individual contractile cells of the heart changes, and that change in electricity caused by an influx of calcium ions actually causes contraction of the muscle. So that's atrial depolarization. That's that first bump. The next thing you see, so you get a bump and then it goes back to baseline right there, and then you see this kind of tall spike, or sometimes what I call the squiggle. And that spike, you can see, has 3 letters on it. There's a Q for the first downward deflection, and then there's an R at the kind of top of the upward deflection, and then there's a S at the bottom of the second downward deflection. So you have a downward deflection, an upward deflection, and another downward deflection. And again, this is idealized. You don't always see all 3 of those deflections on a on every ECG, but here, so that we can talk about them, they're all present. So the first downward deflection is a Q, the first upward deflection is an R, and the second downward deflection is an S. So we call this the QRS complex. And if we're thinking about the electricity of the heart, the first big electrical event is atrial depolarization. The next big electrical event would be ventricular depolarization, right? Okay, then you can see it comes back up to baseline. You get a straight line, kind of just waiting time, and then you get another bump. That second bump is another electrical event, right? So you get atrial depolarization, the signal goes to the ventricles, you get ventricular depolarization. Well, you also have to have what we call repolarization. That means the original electrical status of the contractile cells is restored, right? They go back to being negative, and that's so that they can be ready to depolarize at the next heartbeat. So this T wave we call is ventricular repolarization. Now, if you're following along, you might have an objection here and say, now, wait a minute, what happened to atrial repolarization? Shouldn't atrial repolarization happen before ventricular repolarization? And the answer is yes, it should and it does. So what happens electrically is you get atrial depolarization, and then you get ventricular depolarization and atrial repolarization at about the same time. So what happens is whatever wave would have been formed from atrial repolarization is lost somewhere in this massive QRS complex. It gets masked by that QRS complex, and you're just not able to see it. So yes, it's happening, but we can't see it on the ECG because it gets overrun by the ventricular depolarization, which is the largest, the strongest electrical event that we see on the ECG. Okay, so those are the bumps and squiggles. We're going to largely ignore this U wave for our simplified approach. You don't often see it, to be honest, and it's really not very clinically significant, so we're going to ignore that. And then what you'll notice is after the T wave, then you have another straight baseline until you get to the next electrical event, which is another P wave, another atrial depolarization, another QRS, another ventricular depolarization, another T wave, ventricular repolarization, and that starts over again. Okay, so we have primarily two main bumps and one squiggle or one spike that we need to worry about. Now we also give names to the line in between the bumps and squiggles. So the line between the P wave, the end of the P wave, and the beginning of the QRS complex we call the PR segment, and the line between the end of the S wave and the beginning of the T wave we call the ST segment. We have another couple of intervals that we like to talk about. That means how much time elapsed between the beginning of something and the beginning of something else. So when we talk about the PR interval, we're saying how much time from the beginning of the P wave to the beginning of the QRS, and we call that the PR interval. And then we can do the same thing from the QRS to the T. We're going to say from the end, how much time elapsed from the end of the QRS to the end of the T, and we'll call that the ST interval. You can also do a QT interval, which takes from the beginning of the QRS to the end of the T. And this QT interval is probably more often used clinically than the ST interval. So QT interval is important to remember from the beginning of the Q to the end of the T. How much time did that take? And time is really measured by the vertical line. So you see on this ECG, we've got vertical lines, and then we've got some horizontal lines, right? The horizontal lines give you amplitude, kind of tell you the strength of the electrical signal, at least relatively speaking, not necessarily on an absolute level, but relatively. And then the vertical lines give you time, and we'll talk about that when we start talking about rate. But you're going to measure time by counting these vertical lines, or what we might call these boxes. Each box is a certain amount of time. And you can see down here, it kind of gives that to you. Okay, so P wave, atrial depolarization, QRS complex, ventricular depolarization, and T wave is ventricular repolarization. Now, that doesn't necessarily help when you get to looking at something like this, right? We just pulled out from what we were looking at on the previous slide, we just pulled out one of these. That's what we were looking at right there. This one doesn't even have a P on the one that I circled. It just has, and there's no Q, it just has an R, an S, and a T. So going from what I just showed you to a real ECG can be a bit daunting and even scary looking. So the way that we're going to approach this, the way that we're going to actually learn how to read these, and you'll learn fairly quickly through the process, is we're going to break this up into a systematic approach. So this is really important that we keep the system and we keep it in order. It's in order for a reason. And if you read different books, sometimes the order is a little bit different, and that's okay. The main thing is that you pick an approach, you pick a system, and you stick with it, and you use it every time. Now, this is true especially in your early days, as you're just starting to read ECGs, it's really important that you keep your system and you do your system every time. Otherwise, you're going to find that you're missing things. Okay, so what's the system? The system really consists of looking at 6 different parts of the ECG. And what you'll find in the rest of this course that I'll post online is that you're going to have one lecture on rate with some practice, a lecture on rhythm with some practice, axis, intervals, hypertrophy, and infarction. And we'll talk about what each of those are, how you can discern those from the ECG, what some of the common abnormalities might be, what normal looks like, what abnormal looks like, and what that might be telling you clinically. So we're going to go through each of these: rate, rhythm, axis, intervals, hypertrophy, and infarction, teach you how to see those and to understand what they mean. But what's so helpful here is having a system, sticking with the system, and breaking it up so that you don't get overwhelmed when you look at an ECG from all the bumps and squiggles. You say, okay, this is a scary looking ECG, but I'm just going to find the rate. What's the rate? And you're going to go through and find the rate. After you find the rate, you're going to say, what's the rhythm? Is it regular or irregular? And then you're going to go from there. What's the axis? And we'll talk about that. Let's look at those intervals, the PR interval, the QT interval, things that we talked about on the previous page. So notice that infarction is on the bottom. And the reason we do that is because the most common reason, the 2 most common things that we're looking at with an ECG are rhythm and looking for a heart attack, right? A myocardial infarction. So we put infarction at the end because if you rush to looking for an infarction, you'll likely miss something in here. And we don't want you to miss anything that's important. So we put infarction at the end. Okay, so there will be separate videos coming up for each of those 6 parts with some practice so that you can kind of get comfortable looking at those. But before we finish this lecture, I just wanted to give you a couple of resources that I have used either in my own training or when we trained residents in Africa. We also used both of these books. There, I'm sure, are updated versions of both of them by this point, but these were just some examples so that you could see what's there and you can look and try to find them online. I don't get any kind of, reimbursement from these guys. They don't know that I'm making a video. So this is just what we have used. This orange book we call Dubin. That's what I used in med school and residency. It's a little dated now, but it's a really simple approach similar to what we're going to be talking about. It has lots of examples, which is what's so good about it. And I think if you can get it cheaply, it's still quite useful. This Pocket Brain is what we used for our residents over the years for them to carry around with them so that they could have things to look up when they were looking at ECGs if they couldn't remember something. So I recommend that as well if you're looking for something to carry around with you. All right, make sure you check out the next videos. The next one will be on rate, of course, and then we'll go to rhythm and axis and so on and so forth. And I trust that you will grow in your ability to read ECGs and in your confidence as we go through these together.